Most of the people used to suffer from malaria just because of being bitten by a pregnant mosquito.
A female mosquito.
Country as a whole, there are different species. In the Mach area, it's Anopheles arabiensis. 10 or more years ago, we used to have one called Anopheles funestus, which is actually a much more efficient transmitter. But we had a bad drought one year, and fortunately that mosquito went away. In other parts of Zambia, they're all, of course, female Anopheles. But for instance, if you go up to Lusaka, we find Anopheles gambi is up there. If you go up further to Inchalengi, in the northern part where we work, there's both gambi and funestus up there. But if you look at most of this part of Africa, it's funestus, arabiensis, and gambi. Now we've just recently published for matcha another species called Anopheles squamosus, which used to be seen as a non-transmitter, but we've proven that it actually has malaria inside it.
By the time when I was being affected by malaria, I had a fever, also a simple sign of vomiting, also including body hotness. Yeah, and it brings up more loss of appetite.
Sometimes shivering, feeling weak. Yeah, and sometimes losing appetite.
I feel like shivering, high temperature, sometimes even vomit.
So the most common is usually, it's more common in children than in adults traditionally. And so young children can't tell you how they're feeling, but in adults they just about always will complain of a headache and often will have fever and chills. And generally also feeling achy. We often call it flu-like symptoms. So like in the West we would call this the flu.
Right.
But here it used to be usually malaria. The problem was with young children, they don't tell you. And so if I would see a small child who's not feeding as well, or who's sleepier more, or laying around and had a fever, then we have a very high suspicion for malaria. So 98% of children and adults with malaria just have flu-like symptoms. It's a few percent that get the severe symptoms of convulsions or coma or severe anemia. So in Zambia, the most feared is probably cerebral malaria, where you develop convulsions, you go into coma, and 100% mortality without treatment, and even with treatment, there's about a 20% mortality. The second most one would be severe anemia, which is usually seen in young children, where they go from a normal hemoglobin to a very low hemoglobin, less than 5, within a short period of time, and go into heart failure and die if you don't transfuse them.
In the last couple of years or so, we have piggybacked on a new intervention that's been rolled out in southern Zambia, which is called reactive case detection. What happens there is when a case reports at a health facility, a community health worker is called from the area where that case came from. They go to the household of that case and screen and treat everybody in that household and also neighbouring households.
I'm cleaning the finger, which I would like to prick so that I can collect samples. First, I have to collect blood sample for RGT. This is the test which we are using to diagnose malaria. Because it just takes about 10 to 15 minutes, you know which person. Then from there, I'll also create blood samples for the DBS blood sample. This, of course, is taken to the labs for further investigations using the PCR machines just to check on the malaria parasite. So probably that's the whole process.
Okay. Thank you.
So what we've been doing is we've been accompanying those community health workers, and in addition to the standard rapid diagnostic tests that they use to screen for malaria, we also collect blood onto blood spots to see whether any cases are missed. And we determine that by running PCRs on those blood spots. So the main aim of this intervention is to really identify cases or infections that in people who may not actually ever go to a health facility, either because they're not sick or they generally wouldn't go anyway, and try to eliminate malaria around those hotspots. And also what we do when we go out to these households is we collect mosquitoes from the households. So we're able to combine both entomological outcomes as well as the epidemiological and genomic outcomes from the parasites to really sort of tell a story of what's actually happening in these index case households. So some of the initial work that was done was based on clinical trials documenting cases here in Matcha, and that goes back to the late 90s. From that, we've seen that malaria has really reduced by as much as 90% in this area. Where we're looking to describe the epidemiology, entomology, genomic and parasitological factors of malaria, both here in Matcha, and we also have a site in northern Zambia and also in eastern Zimbabwe. We also, under that project, evaluate interventions as they're rolled out by the national programme. We also do genomic studies, so we look at the different barcode, the genetic barcode of the parasites, and see how similar they are. The main aim of that work is to really see whether we're seeing imported cases of malaria. A lot of it, I think, can be attributed to the ecology, and from the ecology, that's what determines what vector species you get. And also associated with that, in Anopheles fenestis and there's high insecticide resistance. So that means that the interventions that are actually rolled out in those areas are not quite as effective as they may be in the southern part, where the vector is still susceptible to the insecticides. And also community acceptance of interventions. We find in the Matcha area here that, say, something like bed net use, which really depends on communities accepting and using those interventions, is very high, much higher than other parts of the country that we see. And our semi-field system is like a greenhouse within which we release mosquitoes, and we can study their behaviour, we can look at the impact on control interventions within a contained environment.
Well, we're standing here at the semi-field system, which is one of the 3 semi-field systems in the entire continent of Africa. This place is used to imitate a village-like structure in a controlled way. Well, the research we do here in the sphere is the step between the research that we do in the lab and what we can take out to the villages. So here in the sphere we have to test if something actually works in our controlled environment before we can introduce it to the villages. For our first day of a study looking at the device that will be hanged around the eaves of the house and will also be spread out around the house, so it will create a kind of shield that protects the people who will be inside the shield. So we'll be sleeping inside the house, we'll be sitting in the kitchen, sitting on the front porch. And the idea behind this device is that it will repel the mosquitoes, so they cannot enter this house. They cannot enter where the people will gather at night. Testing this is an essential step in bringing a solution, bringing some kind of remedy to the people out there. And with this sphere, we can do so many different studies. We can focus on malaria at the moment, but maybe in the future we will focus on Zika. We can study the behavior of mosquitoes.
We do that experiment. Then the plan is to find the bacteria which is anti-malaria. Then that bacteria should be infected to mosquitoes, so that when mosquitoes grow, they can transmit that bacteria into different generations. Then when these mosquitoes, which are malaria vectors, get the malaria parasite, the malaria should be cured or killed inside the mosquito. So it can be a good atmosphere to do this experiment of eliminating malaria in mosquitoes, or to break the transmission.
So most of the work will be still evaluating interventions as they come out now, really under the idea of a malaria elimination, especially for this part of Zambia. We're also working with other colleagues to look at new interventions that are being rolled out. Some at the moment are being trialled in our semi-field system. So these are vector control interventions, and also work towards better integration of data into the national health system, so that they can really sort of see where is best to apply interventions and how well are they working in different areas of the country.
Yeah, they tend to be more malaria in rural areas than urban areas, and that could probably be accounted for by breeding areas for mosquitoes. Yeah, so in Lusaka, there was actually a decline a bit earlier in the last, maybe I would say 10 years or so, but about 4 or 5 years ago, we did see a bit of an increase in the number of severe malaria cases, cerebral malaria in adults, and more severe malaria even in people who had not traveled outside Lusaka. My assumption would be that the drugs that are used for treatment of malaria have probably played a very big role. So there's a combination, artemisinin combination therapy, ACT, which is very effective in treating malaria, and also the availability of rapid diagnostic testing for malaria. That also should make a big difference. Some of the cases of malaria we used to get in Lusaka were from Chongo, which is just east of Lusaka. So the incidence of malaria in those areas probably has reduced, and so we're seeing less cases in Lusaka as well. So the treatment is the same, I think, as in the rest of the country, because it's determined by nationally. So it's the same standard treatment, which for uncomplicated malaria would be artemisinin and lumefantrine. And then for complicated malaria, usually we would start with parenteral artesunate, and then after 2 or 3 days after a patient improves, you switch to artemisinin lumefantrine, and sometimes quinine is used depending on the availability of the parenteral drugs. So that's the treatment that's given. And of course there would also be supportive treatment depending on the complications that are there. So there could be transfusions, there could be hemodialysis if the patient has severe acute kidney injury. So those are the complications mainly. There is some effect of HIV on malaria, so it would tend to be more severe in patients who have HIV infection. So there is definitely some effect of HIV.
So that's a hard question to answer because, of course, healthcare in Zambia is primarily under the public system, certainly in the rural areas. Right. So it's all paid for through the government program. And we've tried in the past to find out what are the costs. Because the drugs are bought by the government, the people taking care of you are paid for by government salaries, the nurses, the doctors. We did publish something a year or so ago and trying to figure out what the cost of malaria is. What you need to understand, that the main drug we use here, Coartem, if you went to buy it on the market, you'll pay about 10 times as much as what the government can buy it for. So through World Health Organization, there's a special deal that governments can buy Coartem, the drug we're using, very much cheaper. But having said that, for an uncomplicated case of malaria, if you were caught the cost of doing the rapid diagnostic test and the course of medicine without including the caretakers, we're talking less than $5. If you're talking about a complicated case of malaria where you're in the hospital, you're having convulsions, you have to give intravenous quinine or intravenous artesunate, anticonvulsants. In our setting, we're talking about $100 or $150. So as you well know, in the US, you can't even walk into a doctor's office for less than $100 just to walk in the door. And you can't even be in the hospital, especially intensive care unit, for less than thousands of dollars per day. So obviously our costs here are a fraction of what they would be in the US or Western countries. You multiply that though by the whole country, the costs add up. So the healthcare budget in many of these countries is less than $10 per person per year for all their healthcare. Right, the government has said we're going to eliminate malaria by 2020.
That's only about 3 or 4 years from now, so that's quite a lot of work to do in such a short period of time.
I think it's very ambitious. I think it's good to have things to aim for, and how the strategy has been developed, and the final plan is still yet to come out in press. But the strategy talks about measures district by district and area by area, so that by a certain year these many districts should have no cases of malaria reported and so on. I think the way that that's been designed and how they're assigning particular strategies to particular regions based on what the malaria situation currently is a good idea.
I think it can happen for the whole of Zambia. There might be areas of it that can do it, so that the government has in fact said there are going to be certain provinces or districts that they're going to try to eliminate on first. But it's going to take a lot of hard work, and it's going to take money to do it. And like I say, sometimes those aren't available.
I think for the southern part of Zambia, with enough input in terms of resources, effort, government will, and partner support as well, I think it could be possible. There's other parts of the country where malaria is just a really, really different situation to here. If we take, for example, very northern part of Zambia, Luapula province, prevalence is very high. And one of the issues there is it also shares a border with the Democratic Republic of Congo. There's a lot of movement back and forth. And although there may be control measures rolled out in Zambia, they're not being done in DRC. And so that cross-border malaria situation is a real issue. And without those interventions applied both sides of the border, then I can't see that Zambia itself will be able to eliminate malaria in those problem areas.
People love to have meetings and sit and talk, but no one wants to actually do.
Follow me, follow me, take it to my mama. Follow me, inkutwale kumyesu.
Follow me now.